morning, friends and colleagues. Thank you, the chairpersons, for inviting me to this symposium. I've been asked to speak on the treatment of myopic CNV, and these are my financial disclosures. You've heard very elegantly from my previous speaker, Kyoko, on the complications of myopia in what is known as pathologic myopia. Obviously, there is an increasing severity of phenotypes from simple myopia to high myopia, and then pathological changes affecting the macula. We now call this pathologic myopia. And of course, that can eventually lead to complications such as myopic choroidal neovascularization, which is the subject of this talk. For those patients who do develop pathologic myopia, about 5 to 11% of them eventually develop myopic choroidal neovascularization. And the rates of this prevalence is different between populations. For example, in the Caucasian study in the US, it was about 5.2%, and in Asian Japanese eyes, 11.3% of pathologic myopes eventually developed choroidal neovascularization. There are several pathogeneses proposed. There are theories, of course. We don't know for sure which is the main one. But consider mechanical theory being stretching of elongation of the eye. It could be related to heredodegenerative factors or even hemodynamic changes. You've seen the beautiful pictures in the choroid and the effect on the Brooks membrane. Regardless, the long-term outcomes in natural history and untreated myopic CNV is universally poor. They start off with an equal distribution of good vision, a third or 20% with normal vision, but this decreases gradually over 5 to 10 years. Less than 5% remain with normal vision, and in fact, at 10 years or more, 96% of patients end up with visual acuity of less than 20/200. So the natural history of untreated myopic CNV is poor. Before I go into the treatment options, I think one important aspect of the management of myopic CNV is accurate diagnosis. Of course, we have at our disposal now, and we're lucky to have multimodal imaging, which includes spectral domain, OCT, fundus fluorescein, as well as indocyanine green angiography, and more recently, OCT angiography. There have been several studies looking at the relevance as well as utility of spectral domain OCT for detection and monitoring of myopic CNV. For example, the study by Ugo and Francesco's group in Milan showed that unlike typical AMD-related CNV, there is really very little utility in using quantitative OCT changes. We're all used to using quantitative OCT in helping us evaluate activity of CNV, especially in AMD. But in pathologic myopia, the retina is very thin, the changes that occur are very localized, and using central retinal thickness as an indicator of activity is often inaccurate. Similarly, we often do not see significant amounts of intra or subretinal fluid in pathologic myopia. So typical spectral domain OCT morphological changes have to be recognized. We're looking really at qualitative changes on the high-resolution raster scans. Important would be hyper-reflective lesions, and the borders are fuzzy, they are irregular and indistinct. There's often a hyper-reflective core that sits above the level of the RPE, and this often affects or alters the ellipsoid zone. Once we start treating, for example, with anti-VEGF treatment, the fuzziness of the borders disappears, the lesion becomes more consolidated and more well demarcated, the reflective core may regress, and in some cases, the RPE thickens because of fibrosis. But overall, sensitivity and specificity is high, over 90% compared to the gold standard, which is still fluorescein angiography. I think we're all familiar with the OCT features, but it's important again to emphasize that qualitative features are more important than quantitative features. To this date, fluorescein angiogram remains the gold standard. We see that most of these are type 2 or classic membranes that lie and run above the RPE in the subretinal space, and they often give you early leakage with a lacy pattern. However, the ICG is less instructive It's more useful for identifying lacquer cracks and sometimes useful for recurrences from the edge of old foster field scars. So the ICG is not necessarily the gold standard for the evaluation of myopic CNV. Of course, all of us have been using OCT angiography for the past few years, and we're still in evolution. We are still in the learning curve, as Giovanni Storenghi likes to say. In this study by Kurkes and Bandello, in 36 eyes of 28 patients with myopic CNV, they found 4 out of 36 eyes unclassifiable. In clinical practice, this is not uncommon. It is difficult to focus and to image, especially if the axial length is extremely long. The shape can be circular, it can be irregular, the margins may be well-defined or poorly defined, so these are non-specific. But the appearance of the CNV, as seen on flow patterns on the OCTA, gives you an indicator of activity. For example, if you see them in an interlacing pattern, almost lacy, lots of dense network of vessels, they are likely to be active, as opposed to a tangled network, which is long, filamentous vessels with fewer branching. These tend to be lack of activity. Again, the sensitivity in this study was 90%, and the specificity was 93% when compared with fluorescein angiography. This is to illustrate the appearance of an interlacing network on the OCTA, and this is quite indicative of activity. We see this quite commonly in our AMD patients as well. And when you have a tangled network with fewer branches, they may indicate inactivity. So what are the treatment options for myopic CNV in 2017? The current approved therapies on the right are Verteporfin photodynamic therapy, ranibizumab or Lucentis, and Aflibercept or Eylea. Bevacizumab or Avastin is still off-label. We hardly hear nowadays of previously used surgical excisions or removals of choroidal neovascularization, or macular or foveal translocation surgery, and we certainly don't hear of anyone presenting any series on laser photocoagulation. All these for very good reason. The first approved therapy for myopic CNV was really Verteporfin PDT in the pre-anti-VEGF era. The VIP study showed the visual acuity was stabilized when you apply Verteporfin PDT out to 12 months. There was a halving of the possibility of moderate visual loss of 8 letters or more, so 28% versus 56% losing 8 or more letters at 12 months. However, we all know that Verteporfin PDT did not result in significant improvement in vision. Here you clearly see that without treatment in a placebo, patients lost on average 8 to 9 letters at 24 months, and there was a net 0 or 1 letter gain only at 24 months. So obviously, while Verteporfin PDT helped to slow down the disease and limit its damage, there were many disadvantages, including its inability to control disease activity. The patients would have recurrences, and the more time you apply full fluence PDT, you end up with more chorioretinal damage and atrophy, and leakage may persist. So obviously there was a big unmet need, which was filled to some extent when anti-VEGFs became available. It was quite clear from the early onset that myopic CNV patients also had elevation of VEGF levels, and therefore there was a biologic rationale for the introduction of anti-VEGF agents. So ranibizumab was tested in this trial called the Radiance. It was a 12-month phase 3 randomized controlled trial involving 277 patients from both Asia and Europe. And here the study design was quite simple. 2 arms containing standard 0.5 milligrams ranibizumab, and the third arm, the comparator, was Verteporfin PDT, which was the gold standard at that time. I just want to clarify that VA stabilization in group 1 meant that these patients received a mandatory initial 2 doses, not 3, no loading dose. Day 1, month 1, they received 1 injection each, and then subsequently, if there was no change in best corrected visual acuity compared to 2 preceding monthly visits, treatment was stopped. So this group was called VA stabilization. In the second group, there was only 1 mandatory ranibizumab that was administered at the baseline, and thereafter, retreatments was based on activity of disease based on the presence or absence of leakage as assessed by OCT and fluorescein. And that group was called disease activity. And in the last group, of course, Verteporfin PDT, after the 3rd month, they were able to receive repeat PDTs as well as ranibizumab treatment at the investigator's discretion. And here were the results. It was very, very impressive for ranibizumab groups. They demonstrated a 13 to 14 letter gain with a very low number of injections. So this was a different picture from neovascular AMD, and in a way it was a confirmation that these were ideal patients, so to speak, to treat with anti-VEGF. Conversely, when you see the PDT group, they did as we expected. No significant improvement in vision, and after some of them started to receive anti-VEGF, the visual acuity gain started to pick up, but it never quite reaches those who are anti-VEGF monotherapy to begin with. In this study, more than 50% of patients gained at least 3 lines at month 12, so this was a very significant figure. The proportion of patients with CNV leakage and intraretinal edema decreased significantly by over 70% in all the ranibizumab-treated groups. And no new safety findings were identified. In particular, we were concerned about endophthalmitis as well as retinal detachment. None of them were reported in higher incidence. In a subsequent subgroup analysis, we wanted to determine whether or not there were certain baseline factors that might give an indicator of prognosis and response to treatment. For example, you see if a patient presents at age of 65 or above, it's likely that he will require slightly more injections than a patient at less than 45 years of age. Similarly, if they present with lower baseline visual acuity, less than 45 letters, the median number of injections was 4 compared to 2 in the overall group. And the larger the lesion size, for example, at least 2.4 square millimeters, it was likely that these patients would require a median of 5 injections. But regardless, as long as you delivered these injections in a timely and appropriate fashion, you would be able to get reasonably good results and very good visual acuity gains. After the Radiance study, there was a small cohort who were followed up over a period of time looking for recurrences. Of these 41 patients, 17% had 1 recurrence, 10% had a second recurrence, but there were no third recurrences in this group. None of the patients presented had a recurrence in the 4th year of follow-up, and in fact, most of the recurrences occurred within the first 6 months. So I think it is prudent that after you have initiated and successfully treated these CNV lesions, you still have to monitor them quite closely for the first 6 to 9 months. What about Aflibercept? Well, the MIRROR study recruited 121 patients from 5 Asian countries, 75% of these patients from Japan, and you see that it was very simple, 2 groups, the active intravitreal Aflibercept, 2 milligrams, given at baseline, subsequently on a PRN basis, but these patients were monitored at monthly intervals, and then compared to the sham group, who at 6 months received a mandatory Aflibercept, so it was almost like a crossover design. The retreatment criteria, because these patients were treated as needed, was based on disease persistence or disease recurrence, as I've listed, visual acuity reduction, anatomical signs, for example, increase in central retinal thickness by 50 microns, persistent changes of fluid, or persistent CNV and hemorrhage. So you see at 24 weeks, the primary endpoint showed a net gain of over 13 letters in the active treated arm. And here you see a very highly statistical significance over the sham treated, and at 24 weeks, remember all these patients had to receive Aflibercept, there was a pickup in their visual acuity to about 4 letters, but nowhere near the initial treatment with Aflibercept. In terms of 3-line gainers, very similar to ranibizumab results, 50% achieving 3-line gains, and the corresponding improvements in the central retinal thickness. In terms of number of treatments, very similar again to ranibizumab. The median number of treatments was 3 injections in 1 year compared to the sham. No new safety signals similarly, so it's a safe and effective therapy. I just want to end with a simple case study to illustrate some of the learning points. A 77-year-old Chinese female, a high myope, 15 diopters before operation, left eye poor vision from myopic maculopathy and atrophy. She comes in with acute distortion of vision in the right eye. Visual acuity from 6.6 now drops to 6.12, and you see a small macular hemorrhage with peripapillary atrophy, the indocyanine in green clearly showing lacquer cracks, and the atrophy. The baseline OCT illustrating the qualitative changes of the fuzzy border, the hyper-reflective lesion over the RPE, and you can see in these scans successively that there's very little fluid, just simple elevation. Fluorescein angiography shows the presence of a classic membrane, which we would expect in such cases. The ICGA does not show significant hyperfluorescence or even a lacy pattern. With the OCTA, especially on the B scan, you see very nice flow signals through the lesion. And once we've treated with Aflibercept, after a month, visual acuity improves slightly. There is loss of the fuzziness of the border. Fluid has resolved. The lesion is still active, for example, in this section, where the fuzziness of the border still remains. But really, it was after the second injection that the lesion now seems to have resolved, and there are no signs of activity on the OCT. But clearly, if you look at the OCT angiography, you see very nice resolution of flow through the lesion itself. So at that point, of course, I stopped treatment, and 1 month later, while she still remains asymptomatic, visual acuity remains, but you see that the activity has started to return. This is very soon after we stopped therapy, and on the OCTA, clearly that there is some flow returning and she requires a further treatment. So to conclude, myopic CNV is an important sight-threatening complication. Without treatment, they universally lose vision, and the current gold standard is anti-VEGF therapy, achieving very good visual results with a minimal number of treatments, unlike AMD CNV. And we have good evidence now to support this. More injections are required in older patients, those with poorer baseline vision, longer axial lengths, and larger lesion sizes. I thank you very much for your attention.
Thank you very much. Unfortunately, we do not have time for discussion now, so we need to move to the next talk.